Assalamu alaikum class. So today we are going to have the second lecture of epidemiology, and in this lecture we will be covering rates. We have already covered rates in demography and in the initial lectures of concept of health and disease, and you have practiced it almost twice how to calculate different rates. This lecture will give you just a recap of the morbidity rates. Fine. So, going towards the components of epidemiology, which we have discussed in our last lecture, that in epidemiology, the epidemiologist is basically concerned with the frequency of the disease, which is actually the numbers. And when we talk about the numbers, as epidemiologists, we are much more concerned about the rates, ratios, and proportions. And we have discussed in details what are rates, what are ratios, and what are proportions. I have given you the concept of numerator and denominator, the difference between rates and ratios, and why and how do we calculate the proportional rates. So we will not be discussing these rates in detail in today's lecture. So, going towards the frequency and calculation, the most important thing is that we calculate rates, ratios, and proportions. These indicators, which we want to measure, actually measure the mortality rate. It means, as epidemiologists, we are concerned about the number of deaths which are occurring in a community. Number two, as an epidemiologist, we are concerned about the morbidity rates. Morbidity rates means that we are concerned with the pattern of disease and how it presents. And in morbidity rates, we are concerned that what is the actual number of new cases and old cases. So going towards the disability rates, we have discussed them in detail in occupational health, where we have discussed that what are dailies, what are qualies, and I'm not going to repeat them in today's lecture. Fertility rates, we have discussed them in demography, and we have given you assignments and tasks about it. And as an epidemiologist and as demographers, we are concerned that what is the total fertility rate and what is the net reproduction rate, what is general reproduction rate, what is age-specific fertility rate, which indicate the pattern of reproduction in a community. So, while calculating all these rates, we are concerned about the indicators which indicate the state of the health. And these indicators should be valid. It means they actually are calculating what they should be calculating. It means that if I am interested in number of new cases, it means I have to calculate the incidence rate. Although I can calculate the point prevalence to know the number of cases present at that particular time period, but the true picture will be calculated only by the incidence and not by the point prevalence. It means then, as an epidemiologist, you have to decide what is the valid tool or what is the valid indicator you have to measure what you want to measure. Another important thing is reliability of the indicator. It means that the indicator, when it is used in a specific community in specific time period, it gives reliable results. It means the results are always the same if the community is same and if the indicator is the same and if the tool is the same. If the indicator is giving different results in the same community, it means this indicator is not reliable. Then it should be accurate, it should be specific, and it should be sensitive. Specificity and sensitivity we will be discussing in detail when we will be discussing the um, screening tests in community, which will be following after the lectures of epidemiology. So specificity means the ability of a test to measure the true negatives in a community. And sensitivity means the ability of a test to calculate the true positives patients in a community. So these are the basic indicators and basic requirements of the indicators which should be used by an epidemiologist. Going towards the indicators, as I have already mentioned, that Mortality rates, disability rates, fertility rates have been discussed in detail, and even the morbidity rates have been discussed in detail. But just to give you a recap of morbidity rates, actually they measure the extent of disease, injury, or disability in a defined geographical population. But now the WHO has given us disability rates, so we do not calculate disability rates under the morbidity rates. We are only concerned with the extent of the disease and the disease pattern in morbidity rates. For calculation of morbidity rates, we can calculate sickness rates, attack rates, and secondary attack rates. And the most important ones are incidence and the prevalence rate. All these rates, sickness rates, attack rates, and secondary attack rates have been discussed in detail in our previous lectures. So will today we will be discussing only the incidence and prevalence in detail. So as the name is suggestive, incidence means the total number of new cases which are occurring in a community, and prevalence means the total number of old and new cases which are present in the community. This pattern shows the pattern of disease occurrence in a community. Let's suppose this is a community, and all the cases, new cases which are occurring in the community will be labeled as the incidence, and all the cases which are new and old, when they are combined together, they will be measured under the prevalence. And the number of cases will reduce only if the deaths in the community will occur, or the patients will cure in case of infectious diseases or other diseases. So this picture is very important in community medicine, and we call it as an epidemiological bathtub. Let me give you an example. This is a normal population and a healthy population. And in this population, you go and find out that what are the cases, what are the number of cases which are hypertensive. So as a researcher, what will you do? That you will start survey from here, and you will ask this particular person that do you have a history of hypertension, or are you suffering from hypertension? And if he says no, then you will take the blood pressure, and if you find out that this particular person is hypertensive, you will label it as a new case. And if this case will give you a history that is already hypertensive, then it will be counted under the heading of the prevalence. If you find out new cases in the community, then you will be calculating incidence rate. And if you are calculating old and new, all cases present in the community, that will give you prevalence. Remember always, prevalence gives the true burden of disease in a community. So this is a normal healthy community, and these cases have been diagnosed by you. These are the new cases. So while calculating the new cases and incidence rate, you will be much more interested in the total number of newly diagnosed cases in case of numerator. And in calculation of prevalence rate, you will be interested to know that what is the number of all old cases and new cases in the community. This is the difference in the numerator. And going towards the denominator, when you will be calculating prevalence rate, the total number of population or total population is your point of interest while calculating the prevalence rate. But in case of incidence rate, the total number of new cases occurring in susceptible population or in population which is at risk will give you the incidence rate. It means there is difference not only in the numerator but also in the denominator, where in denominator of calculating the incidence rate, you will take only the susceptible population or only the population at risk. So moving towards this picture, one of your OSPE question. This is known as epidemiological bathtub, which shows that this is the number of new cases which are occurring, and old and new cases combined together makes the prevalence. The prevalence will decrease with the number of deaths, and the prevalence will increase by the increased number of recurrence of cases. Fine. Prevalence will also be decreased if there is cure available for the disease. So the modern epidemiological bathtub has two exits. One is mortality and number two is cure, which decreases the prevalence rate. And the prevalence rate increases by increase in the incidence rate and increase in the recurrent rates. One of your OSPI question. Fine. This picture has been shown to you and repeatedly, and it shows that a researcher has started his survey on October 1, 2004. Then he revisited the community and surveyed again on April 1, 2005, and he concluded his research on September 30th, 2005. So all the cases which are currently present at this point in time will show the number of cases or the point prevalence of October 1, 2004. It means the case number 1, case number 2, case number 4, case 5, case 8, and case 9 are basically indicating the point prevalence on October 1, 2004. So again, if I ask you that what is the point prevalence of April 1, 2005, then only case number 6, case number 7, and case number 10 will be showing you the total number of new cases, and the point prevalence will be shown by the case number 4, case number 5, case number 6, case number 7, case number 9, and case number 10. So at this point, if I ask you to calculate the prevalence, all the new cases which have emerged during this time period, which are case 6, 7, and 10, plus all the old cases which have started from the previous time period will be included. This case will be excluded because this case has actually suffered from death or from the recovery. Fine. So going towards the 30th September, again the cases point prevalence will be indicated by case number 1, case number 7, case number 9, and case number 10. And I'm sorry, I forgot to mention that case number 1 is also present on April 1, 2005. So at point prevalence will indicate the total number of old and new cases at that particular time period. Period prevalence will show that if I ask you that what is the period prevalence between October 1, 2004 to September 30th, 2005, all the cases will be included. All the cases will be present during this time period will be included to show the period prevalence. So as I have already mentioned, the total number of new cases of a specific disease in a given time period in a specific community divided by the population at risk during that period is important. Multiplied by 1,000 will calculate the incidence rate. So the numerator and denominator both are different when we are calculating the incidence rate. Fine. So for these, you can please calculate the incidence rate. If there are 500 new cases of tuberculosis in a population of 30,000, what will be the incidence rate? Please calculate and submit your assignments within 5 minutes. Okay, what are the uses of incidence rate? It helps us to control the disease. It helps us to find out the etiology and pathogenesis of the disease. Moving towards the prevalence, it is divided into point prevalence and the period prevalence. So the number of cases of a specific disease which are present, either they are identified at this point in time as new case or they were present previously as old cases, divided by the total population at that specific area in specific time period into 1,000 will give point prevalence. And if we extend the point prevalence from one period to another period and calculate the total number of cases of a disease present in the population in that period, not specific point, in that period, divided by the total population in that period into 1000 will give us the period prevalence. Fine. Another important relationship between the prevalence and incidence is that always the incidence is independent of the duration. But the incidence, when it is multiplied by duration, it produces the total number of prevalent cases. It means if the new cases are occurring in a community and if we consider it for a longer time period, so the number of new cases emerging in that community calculated by the incidence rate multiplied by the duration will give us the prevalence of the disease. What are the uses of prevalence? It's the only truly depicting rate which tells us about the magnitude or the burden of disease. It identifies high risk groups. It has helped for administration and planning. The government uses health planning and health plans for all those diseases who have high prevalence in the community. For example, in Pakistan, we have tuberculosis control program. In Pakistan, we have hepatitis B and C control program. We have polio control program. Rather, it has been converted into polio eradication program. So all those diseases which show high prevalence are of high public health importance, and government make health plans to overcome these problems. It is also used to monitor the health plans, that at the start of the health plans, the number of cases was this, the prevalence rate was this, and by input of so much resources of time, place, and person, the number of cases have been reduced or they are still increasing. Prevalence is used to monitor the health programs which are developed by the government as well. So this is just show you point prevalence is measured in point time, period prevalence is measured in period, and the difference between period and point prevalence can be calculated by the questions which you ask. That, for example, if you ask a question that do you currently have asthma, it means you are interested in asking about the point prevalence, because the currently you are having asthma. It means you are interested in calculating presence of asthma at this particular point in time. Have you had asthma in last 5 years will give you the period prevalence. And have you ever had asthma during your lifetime? It will give you lifetime incidence. But if you go in a community and you find out a new case of asthma, will give you a new incidence of that particular disease. So, what are the factors which affect the prevalence? We all know that migration of people affects the disease pattern. If the total number of cases is increased because of the migration, for example, somebody was affected by the COVID-19 and they have traveled from outside the country to inside, they have caused increased prevalence in that susceptible population in which there was no case available. And immigration of the susceptible cases, because it affects the concept of herd immunity. If in a herd the number of susceptible cases increase as compared to the number of cases who are immune, definitely the rates will increase. If the healthy person are going out or they are migrating out, again the susceptible population is increased in the herd, and it can cause increase in prevalence. If there is prolongation of life, or if the survival rate of the community is high, it can increase prevalence of non-communicable diseases. And if the new cases are occurring, definitely it means the incidence is increasing, and incidence multiplied by the time period for which it is available will help us in calculating the prevalence. So these are the rates which affect the prevalence, and I have quickly gone through this lecture because I know that we have covered this subject at least 3 times before in our routine lectures. It was just a recap of morbidity rates. Dr. Iram will be giving you assignments in the next lecture, and your presence will be marked if you will not copy, cut, and paste the assignments, and if you will do it yourself, then you will be marked present. Thank you so much.